Hello, I'm Carol Ireland, CEO of Epilepsy Action Australia. Today our topic in the Ask an Expert series is women with epilepsy. And I'm joined today by Dr. Michelle Kiley, the Director of Epilepsy Services at Royal Adelaide Hospital. Now, Michelle has many roles and interests, one of which is epilepsy and women. Welcome, Michelle. It's great to have you here today.
Thanks, Carol. It's great to be here.
And it's great to have Rosie with us from time to time as well.
She's not going to be left out, it seems.
Michelle, I understand that the incidence of epilepsy among men and women is approximately the same. But obviously, men and women aren't the same. While it's not true that men are from Mars and women are from Venus, there are some very real differences, physiological, psychological, and hormonal. Can you summarise for us some of the issues that might be specific to women with epilepsy?
Certainly, Carol. I mean, they're largely based around reproduction, really, and they start with considering in a adolescent girl drug selection when one's thinking about what forms of contraception she might want to be on, and then the broader issues moving forward with pregnancy. And then everything that pregnancy entails, delivery, breastfeeding, postpartum care, right through to menopause. So I think that the physiological, biological differences are what necessitate a significant difference in management. There is no doubt that managing women with epilepsy is much more complex for those reasons than managing men with epilepsy.
So I expect we might be talking a little bit today about hormones.
Indeed.
Could I start with perhaps a question around puberty? Puberty is a complex time for young girls. Again, are there any particular considerations for young girls with epilepsy around puberty?
Well, puberty, of course, is marked most notably in young women by menstruation, and the hormonal fluctuations that occur in the menstrual cycle can impact upon seizures. And in some forms of epilepsy, as you know, Carol, broadly speaking, about 1/3 of our epilepsies have a genetic basis, but about 2/3 are what we refer to as focal epilepsy. And in the focal epilepsies, some women's seizures are much more vulnerable at certain times of the menstrual cycle. So some women will come to you and they say, it seems to me that my seizures are occurring around the time of my period. And there are very, very clear biological reasons for why that does happen. Now, it doesn't happen to all women with focal epilepsy by any stretch, but it certainly happens to a certain percentage. And therefore, one's got to be mindful of that. It's very helpful for women to know why that's happening. So the first thing is to explain to them the biology of that and why their seizures are occurring more commonly at certain times of the month. But then there are management strategies that we can introduce if that happens to be the case.
Michelle, I'm going to ask you some specific questions that have been put to us by clients of Epilepsy Action Australia. You've already mentioned menstruation earlier, but one person asked, why are my seizures happening only just before menstruation?
Yes. Well, the two main female hormones are progesterone and estrogen, and for most of the cycle, they have not dissimilar levels, but there are certain times of the cycle. Ovulation is of one time, and some women get their seizures more around the time of ovulation, not just before menstruation. And at ovulation, the estrogen levels rise before the progesterone levels rise, so you've got a slight imbalance. And then just before menstruation, your progesterone levels fall before your estrogen levels fall. And why that matters is because progesterone has anti-seizure effects, whereas estrogen has pro-epileptic effects. And it's not that estrogen causes epilepsy, of course it doesn't, or all women would have epilepsy. But if you've got a vulnerability, you've got something in your brain that is resulting in focal seizures, if you like, the estrogen is capable of just tickling that up, dialing that up at that certain times of vulnerability when its levels are higher than the progesterone levels. Mm-hmm. So that's why, that we see some women will have seizures more around ovulation, some will say it's just before their menstruation. And it's just a slight imbalance, an excess of estrogen driving whatever is the underlying cause of the epilepsy. And so that's the simple biology behind
my goodness. So another person's asking, what can I do if I'm having seizures associated with my menstrual period? Can I take higher doses of my medication? Is there anything I can actually do about it?
Yeah, great question. I think there are several approaches. So I think what we call the type of epilepsy when a woman's seizures are largely around those times of the cycle catamenial epilepsy. Now, a lot of women will be of the impression that that's largely when their seizures are occurring, but the first thing you've got to do is get patients to keep a diary over several months to have a look at the pattern. Because whilst they might get some around that time, you see they're also getting some seizures at other times as well. And so in that group of women, my approach is just to try and lift the whole threshold if you can. So for example, if they're on one drug and it's not working, I'll add a second drug, or I'll think, is there room to increase the dose of the first drug? So if they don't have pure catamenial epilepsy, that will generally be my approach. If a woman does have more pure catamenial epilepsy, so the vast majority of their seizures are occurring at those vulnerable times of their menstrual cycle, there are three approaches. One approach is to get them to increase whatever they're on. So for example, let's just say they're on levetiracetam, 500 milligrams twice a day. They might take 750 milligrams twice a day for about 10 days over that vulnerable period, perhaps starting 3 days before their cycle and for sort of 6-7 days through their cycle. It's important to note that, of course, these sorts of strategies are only really helpful if a cycle is fairly regular, but for most women it is. The other option is to add a drug in, so you might not be increasing the dose of the drug they're on, but you might add a dose in, and a medicine that works well for that, an anti-seizure medication, is clobazam, or commercially known as Frisium, and that can be very effective using cyclical clobazam around the menstrual period, and that can also help. And then you can try hormonal manipulation, and there is a set protocol for giving progesterone around that time of the cycle, given its anti-seizure effects. That's a little bit more fiddly, and I don't find it quite as successful, but I've had 1 or 2 women in whom that's worked to treat. Another hormonal strategy sometimes is using the oral contraceptive pill continuously. So 3 weeks of active pill, but then no week of sugar pill, so that the hormonal levels don't drop. You go straight back into the active pill. So you're doing a 21-day cycle as opposed to a 28-day cycle. I must confess, in my considerable experience of trying that, I don't find it nearly as helpful as the other strategies I've spoken about.
Okay, so really that adjustment of the anti-epileptic or anti-seizure medication is the main way to deal with this.
I believe so, yes.
Another person's asked, will my seizure medication affect my birth control medication? Yes, but absolutely, but not all of them. That's the first thing to say. So some of the older drugs we used to use, and we still use them, as drugs like carbamazepine, commonly known as Tegretol, a good drug for focal epilepsy, for example. We still use it quite a lot. It's what we call an enzyme-inducing drug. So what that means is it makes some of the enzymes, it turns the enzymes in the liver on and makes them more active. It's not a bad thing, but an effect of that is other medications taken concurrently can be more avidly metabolized and broken down. And the oral contraceptive pill is one of those agents. So for example, the enzyme-inducing drugs like carbamazepine, to a lesser extent to pyramate, and some of the older ones we hardly ever use anymore, will make the oral contraceptive pill less effective. So there's a higher risk of failure with the pill. So then other strategies, if a person's on a certain drug that will do that, we'll either say, well, you should be using a high-dose contraception, or adding in barrier contraception, or thinking about a different form of contraception altogether. And it's worth noting that carbamazepine also renders implanon devices ineffective. So one certainly has to be knowledgeable about how the anti-seizure medications interact with various forms of contraception, because the last thing you want is contraception failure. So one person's actually asking, is there a preferred method of birth control for somebody with epilepsy?
It's a good question, and I never like to say there's an absolute preferred method, because, you know, as we know, a lot of women will tolerate one form of contraception and not another. And so if you take something like an intrauterine device, and of course the Mirena devices are the most popular of those at the moment, they're perfect in a sense. I love to see young women with epilepsy with Mirena devices in, because they act locally, so they don't interact on the anti-epileptic or anti-seizure medications, and the anti-seizure medications won't reduce the efficacy of the Mirena device. But there are a lot of women that don't like the idea of an intrauterine device, or they get, you know, problems with it, and so they'd like to use other forms of contraception. And I think, you know, the other way of looking at it is we don't always need to be finding the right form of contraception to suit the anti-epileptic drug. The other way of approaching is, well, could we use an anti-epileptic or anti-seizure medication that is not going to impact on any form of contraception? And it's fair to say that a lot of our newer agents don't have any impact. So a lot of the agents that have been developed since the 1990s are quite clean in that respect, and we've got much more available to us when we come to contraceptive choices. It's just worth noting, though, that the only drug that has the reverse effect is lamotrigine. So if a patient is stable on lamotrigine and then you add in the pill can in fact increase the metabolism of lamotrigine. So there are things one needs to be mindful, and it's certainly always worth, the individual engaging with their epilepsy specialist about all these questions and all these issues, because they are complex, and the GPs, they've got to be across a lot, and they're not often across some of these nuances. So it's up to us to guide both the GPs and the individual patient.
Michelle, I'd like to talk to you a little bit more about pregnancy and epilepsy. Many young women with epilepsy want to have a family. Many young women want to have a family. There are a lot of questions put forward from this, a lot of very specific questions, but just in general, what's the best way to plan for a pregnancy if you're a woman with epilepsy?
Yeah, that's a great question. And I say to all my young women, the key is planning in itself. And it's nice if, it's got to be remembered that 38% of pregnancies are not planned. So that's going to happen, and we work around that, that's fine. But it's ideal if women with epilepsy can plan, because there are two important things to consider. One is, what are the anti-seizure medications the individual's on? Firstly, do they still need to be on them? And secondly, can we rationalise them at all? And three, is there something safer they could be on for the sake of, fetal development? And then the other main aspect is, if we can get the best seizure control in the 12 months before the pregnancy, we know that's a good indicator of seizure control throughout pregnancy.
That's good planning, isn't it?
Yeah, absolutely.
So what are the complications that might arise for a woman with epilepsy?
During pregnancy?
Yes, during pregnancy.
Well, there is evidence that a woman will have more seizures during pregnancy, but I think that's improving. I think a lot of that was occurring more so in the literature when we weren't as mindful of the need to measure certain anti-seizure medication levels in pregnancy. And lamotrigine is the main culprit here. We know that throughout pregnancy, just like the pill can chew up lamotrigine and make it less effective, pregnancy, the hormone rises in pregnancy, increase clearance of lamotrigine and make it less effective. That happens to a lesser extent to levetiracetam, commonly known as Keppra. And so monitoring levels and adjusting doses is important to reduce the risk of seizures in pregnancy. And the main risk of seizures in pregnancy, not so much seizures with impairment of awareness, but with convulsive or tonic-clonic seizures, is in fact, there's a small risk to the fetus from injury, but the main risk is to the mother. And we know that mortality in women with epilepsy during pregnancy is increased tenfold compared to women without epilepsy during pregnancy, and that is largely due to SUDEP, sudden unexpected death in epilepsy, which is a consequence of almost invariably convulsive seizures. So seizure control in pregnancy is more important for the mother than it is for the fetus.
That's very significant, isn't it?
Absolutely.
It's an actual risk to the mother's life. So one lady actually asked, which medications should I or should I not be taking during pregnancy? I imagine this is quite individualised, but what would your answer be to that?
Well, it's a spectrum. And the one that we really don't like to see women on ideally is sodium valproate. That has got the highest risk of fetal malformations, congenital fetal malformations of any of the anti-seizure medications. So it's important to remember, and I do remind women of this, that even healthy women not taking medication have a 2.5 to 3% risk of having a child with a congenital malformation. It's not zero. So when you take a drug, for example, like carbamazepine or topiramate, and that's got a 4 to 5% risk, I say that's only marginally increased compared to the general population. And you've still got a 95% chance of having a very normal baby, and any significant congenital malformations we will detect with fetal ultrasonography. Sodium valproate at high doses, so we're talking 500 milligrams twice a day and above, so 1 gram twice a day and above carries, well, it depends on which registry you look at, but anywhere from a 10 to 30% risk of congenital malformation. So that's the one we really say we don't want to see women on. Whereas, for example, levetiracetam has a negligible increased risk and lamotrigine a very small increased risk, so they're the safest. Now, that's putting it simplistically. One has got to marry that together with what type of epilepsy an individual has and what's the best anti-seizure medication for them. So you can't completely, for example, blacklist sodium valproate, because there are some individuals with genetic forms of epilepsy who will only be controlled on sodium valproate. But our goal in those women is to try and get the dose as low as we can and have them on other medications for epilepsy. For example, levetiracetam is good for genetic generalised epilepsy, but not as good as sodium valproate. But our goal in that scenario will be to have them on some levetiracetam plus some lamotrigine and just a snifter of sodium valproate, just 100 or 200 milligrams twice a day might be enough. And the congenital malformation rate seen with sodium valproate is dose dependent. So whilst you have a significant risk of malformation at bigger doses, 700 milligrams and above, we know that for 300 to 400 milligrams a day, your risk is much lower. And it's back almost with where you're looking at risks for topiramate and carbamazepine.
So close medical or medication management is really important.
That's the key, Carol, of the planning, because you want to be doing all this before the woman's pregnant.
In advance.
It's because women often will present to you, when they're already 6 to 8 weeks pregnant, and organogenesis, the formation of the organs in the fetus, occur in the first trimester. So we want to have all this sorted out if we can before the woman is pregnant.
Yes,
yes. And that's the ideal scenario. But it's worth being mindful of the fact that we've become far more cognizant over the last decade or so of not just congenital malformations, physical defects of the fetus, but effects that these drugs can have on a child's development, both cognitively and behaviourally. And there have been large transatlantic studies done now looking at a number of anti-epileptic drugs to see whether or not they affect the offspring's IQ. And again, the bad kid on the block is sodium valproate. Again, this is dose related. So we might have once thought, oh, well, if we can just put a woman on a lower dose of valproate in the first trimester, and then if we need to increase it, we now know that we shouldn't be doing that, because it seems to be valproate exposure throughout the pregnancy that can lower the verbal IQ in the offspring. And we've also now got studies that show that valproate is associated with increased risk of autism spectrum disorders. So there is a lot more to consider now in the decisions we make about the right anti-seizure medications when a woman wants to become pregnant.
And Michelle, what about the seizures themselves? Can a seizure hurt an unborn child?
The chance is quite low, unless there was a significant sort of fall on a sort of, pregnant abdomen. There's a slight chance of a traumatic injury. Or if a woman went into status epilepticus, which is a prolonged seizure from which they don't recover, and by definition that's a seizure of more than 5 minutes duration, then there's potentially a chance of not enough blood supply getting to the fetus. So there are potential risks, but seizures in and of themselves, as I said, are more of a problem to the mother than they are to the fetus.
Yes.
The medications are more of a problem to the fetus, but that's why when often we talk about this, we talk about the scales. We're trying to get the best mix we can for the fetus. We don't want it to have congenital malformations, we don't want it to have a lower IQ, we don't want it to have behavioural disorders, but we don't want mum to die of SUDEP either. So, it's a fine line, you've got to get that balance right.
Sure. We have one person that's been concerned about having a seizure during delivery. Is that something that's common?
I wouldn't say common. It is said to be the most vulnerable time throughout pregnancy, but that's interesting because in my 20 plus years of working as an epilepsy specialist, I've never had a single woman, touch wood, have a seizure in labour. And I always say to women, you must choose whatever form of delivery you're most comfortable with. I find a lot of women are anxious about this and they will elect to have a caesarean section, but I try and stress to them that's not really necessary. And I say to them, the most important thing is make sure you have a birth in a hospital medical environment. Home births in this scenario would be a disaster. But if you're in a supervised medical environment and you have a seizure, then it can be terminated very rapidly with intravenous medication. And if there's some problem with the labour, then it can progress rapidly to a caesarean section or an assisted delivery. As I said, I've rarely ever encountered this. What I say to women, I say, if you decide to have a normal vaginal delivery, there's no problems with any form of pain relief, that's perfectly fine. And I say, I want your partner or your birth partner, whoever that may be, their job is to make sure that you get your anti-seizure medication. Because while the midwives probably should be doing it, everyone might be a bit distracted by the birth. But if it's a long labour, your job is to make sure the anti-seizure medications aren't missed.
Absolutely. So let's move beyond the birth, and we've got hopefully a very happy, healthy baby. Some of the questions that have come up are around breastfeeding. Yeah. Can I breastfeed my baby if I'm on anti-epileptic medications?
Absolutely. There's no contraindication to breastfeeding with any type of medication. There were some we used to worry about maybe being a bit sedating or the baby not being able to break the drug down, but we now know that's not true. I say to every woman, this baby is going to have been exposed to far more drug in utero than it is in your breast milk. And in a way, it's almost weaning the baby off the anti-seizure medication. So it's not a concern. Breastfeeding is as safe as houses.
Okay, that's terrific. Another thing that a lot of young mums face, of course, is lack of sleep.
Yes, and so that's one of the most important issues when it comes to management in that afterbirth period, and that starts on the labour ward, Carol. I write a letter for my patients to give to the midwives and say that I want the mother to be left alone for 12 hours after the birth. I want them to have protected time to catch up and recover. And, depending on where you are, that happens to a variable degree, but if you write a letter saying you insist upon it, it happens more commonly than it might otherwise, because it is important. And as you know, some types of epilepsy are far more vulnerable to sleep deprivation than others, particularly our genetic epilepsies. So that's the group it's most important in. But I think, I think it's nice for all of our patients with epilepsy just to have a little bit of a breather and recovery time, particularly if they've had a normal vaginal delivery, a long labour.
Sure. And look, you did tell us that the best way, to have a safe pregnancy if you're a woman with epilepsy is to plan.
Yes.
Any particular advice for those pregnancies that you mentioned that come along that weren't planned?
Yes, so I just say to a woman, if you get pregnant, please do not do anything, because every now and then you hear the very sad tale of a woman that's just gone off and had a termination because she thinks that her anti-seizure medications, she shouldn't have been taking them and it's just going to be a disaster. And so without really any medical advice, they go off and have a termination. And there may be complex reasons for that, but I have known one or two women have done it simply because they thought what they were taking was bad for the offspring, for the fetus. So I say, look, just contact me. The moment you find out you're pregnant, just contact me and we'll get together and we'll have a talk about, what you're on. Because I said these days, most of the medications you're on that we've got women on are relatively safe. So it's not probably going to be a major issue. Just let me know and we'll have a talk about it, and we'll have a talk about the need to monitor medication levels if necessary and move forward.
Being at home as a new mum, tiny baby, most of us have experienced, or a lot of us have experienced that. Sleep deprivation certainly goes into that earlier period, doesn't it? Coping at home can be really challenging.
So first thing, you hope that the patient has a supportive partner. And I often sort of say, look, having your partner or family member or close friend, if possible, help with feeding overnight is really important. And, if that means expressing or sort of having a combination of formula and breast milk, having someone to assist so that the individual with epilepsy can get a good chunk of sleep, that's very, very helpful. So I try and, again, bring the partners in to this conversation as early as possible. And most of them are very willing to help out and do that.
They need to share, don't they?
So that's the first thing. And then, there are safety issues. So some of the things I will tell young mums or new mums is, think about, if I had a seizure right now, would that be a disaster, and how can we mitigate the risks of that? So I say, change the baby on the floor. Unless you've had a caesarean section and it's a bit hard to get up and down, you're better off changing the baby on the floor than on a change table, particularly as they get more wriggly. And because the last thing you want to do is have a seizure, be out of action, and they've flipped off the change table. So even on the bed, if necessary, even on a double bed, would be better than them being up on a change table. Bathing the baby at home. I say, if you had a seizure at home and there was no one there, that would probably be a bit of a disaster. And so, I'll say, better off to bath the baby when someone else is home, when your partner gets home or mum and dad come around or whatever, just so that there's some extra support there if something were to happen. Most women sit down to breastfeed anyway, but I say just be mindful of the fact that you're not walking around the house with baby on your breast, that you're sitting down. I know that's what the vast majority of women do, but just a simple safety strategy. So they're the main things. And then, of course, there's a form of epilepsy, as you well know, called juvenile myoclonic epilepsy. And one thing that happens, one form of seizure in that type of epilepsy is the myoclonic jerk. And women have dropped babies having myoclonic jerks. And so if they've got that type of epilepsy and they're vulnerable, I say try again, minimise how much time you're walking around with the baby. But equally, don't put up with that. That's probably happening because you're sleep deprived, and we should probably be reviewing your anti-seizure medications, and they might need increasing. So if you are having jerks during that period, please contact your epilepsy specialist and let them know so that we can hopefully get those under control.
Seeking support and advice is important.
Yeah.
Michelle, Epilepsy Action Australia is the major supporter of the Australian Pregnancy Register. I wonder, just for our viewers, could you mention what the Australian Pregnancy Register is and why it's important for people to register?
Yes, well, look, it's a wonderful service that is provided by a large academic group based largely in Melbourne, run by a number of epileptologists and data collection nurses with the support of associations such as yours. And what it does is it looks to collect data on women with epilepsy who are pregnant and are on anti-seizure medication. So what clinicians are asked to do is to refer women with their consent to the registry. One of the research nurses contacts them and gets their consent to be involved. And it's not complex. They just acquire a bit of data, how old the patient is, which pregnancy is this, how far through their pregnancy are they, and what seizure medications they're on. They track throughout the pregnancy as to whether or not there are any changes in medication doses or medication types, and then they follow up on the well-being, the outcome of the offspring, looking for congenital malformation rates. And it's only through a service such as this and other registries around the world that we have learned about the detrimental effects, for example, of sodium valproate. We didn't know back in the 1990s that sodium valproate was associated with a high congenital malformation rate. And it's only, and as I say to my patients, this is invaluable. You're de-identified. So, it's not as if you will be in any way identified by being involved in this data collection project, but we can then tell, and it's not just, we can tell all sorts of things, all sorts of data are derived from the Australian Pregnancy Registry. For example, the incidence of seizures throughout pregnancy, the risk of seizures throughout pregnancy. A lot of the information, in fact, I've been telling you today is data we know from these registries. And the Australian Pregnancy Registry is an important contributor to this body of world literature, and it's invaluable. So I really can't stress enough the importance of this, A, to my patients to participate, but B, to my fellow clinicians to encourage their patients when they are pregnant to become involved.
So a woman who gets involved is helping women who want to have families into the future.
Absolutely. And I'll say that to my patients, that right now you're on a drug that we don't know what the risk of that drug is. The question is, should you still be on it? But if we decide to go ahead with this pregnancy, it's the outcome of this pregnancy that's then going to inform a woman in 5 years' time how safe this drug is. So it's so important.
Oh, terrific. So moving on from this very important topic of pregnancy, there were some other questions on different issues. One person actually said she's had a lot of weight gain because of the medication she's taking. It's the one that's best for her seizure type, but the weight gain is clearly bothering her. Are there other options for her?
Well, possibly is the answer. And generally speaking, if there are, they're worth addressing, because obviously, weight gain, excessive weight is not healthy. And if and this is not just, of course, a gender-related question. You have the same conversation with my male patients. They might come in and they're on this drug and they're told it's the best one, but they're 20 kilos overweight, and and I think if there's a suitable alternative in them too, I should be trying to maybe transition them. And you've got to obviously counsel them about the risks of changing medications, and it may come at a risk of breakthrough seizures, and it's going to have implications for not being able to drive and all sorts of things. But it's a conversation worth having, and at the end of the day, that individual can make up their mind about what they'd like to do. But I think they should be given choices. Now, there's always going to be, and I can think of I can see the faces of 2 or 3 people in my mind who need the drug they're on for their epilepsy. We've tried everything else, but they are overweight. And then I just try and counsel them on weight loss strategy. I mean, I'm not a dietitian, but I recommend a dietitian, or I might talk to them about strategies, or what weight loss agencies I think are more effective than others, or are better run than others, or have better strategies than others, and engage with them about weight loss. And they're often, it's a topic close to every woman's heart, Carol. And so I'm always very happy to share my experience.
I'm with you, Michelle. Michelle, menopause is another period in our life, another stage in the life of a woman. Do seizures get better or worse or stay the same during menopause?
Good question. Not a lot of great data, but from what we know, it tends to be a bit of a rule of thirds. Some will get better, some will get worse, some will stay the same. That's general. If we go back to focusing on women that have catamenial epilepsy, so they're more vulnerable to those hormonal cycles, they potentially may have some improvement. In fact, they probably have some exacerbation in perimenopause, but improvement postmenopausally.
Okay. And on the question of hormone replacement therapy, or HRT, will that affect seizures?
Possibly. It's a difficult question to answer. Again, the data is not robust. The wisdom or advice tends to be, particularly if you've had a hormonal form of epilepsy, or epilepsy that's been more aggravated by hormonal fluctuations, it's probably best avoided. But having said that, Carol, it's a bit like women that have migraine and are advised against hormone replacement therapy because of the increased risk of stroke. At the end of the day, I let a woman make an informed decision. I tell her how big I think her increased risk of stroke is, and she's got to weigh off the benefits of HRT, and they might be everything from symptomatic relief to reduced risk of osteoporosis, etc., etc., etc. And I'll often send people, I'll give them the neurological view on HRT with their migraine or their epilepsy, but I will very much encourage them to go and speak to their gynaecologist about the potential gynecological and other advantages, and then make an informed decision. I don't think it's an absolute.
Michelle, it seems that education for women is really important. Self-education, getting advice and information, but there is choice. There is obviously a lot of choice, but all women should be aware of how their epilepsy and treatment may affect their health through the various stages, I guess, of our lives. Is there anything else you'd like to add about women and epilepsy that we haven't touched on?
No, look, I think the key is to be as informed as possible. Every person with a medical issue to be as informed as they can be. But I think with women and epilepsy, there are so many more complexities, and they want the answers. Knowledge is power. But as you know, consultations are a finite thing. Patients leave having forgotten to ask you questions or think of things afterwards. So it's nice for them to have resources to be able to go to, reliable, trustworthy resources. I certainly tell patients to avoid blogs. So we want them to go to reputable sites where they know the information they're getting is reliable. And there are a lot of good websites, and obviously Epilepsy Action has a wonderful website. And your association, Epilepsy Action, developed the Epilepsy Key some years ago, and I still give that to my patients and say, look, this is like a USB, put it in, log on, and it'll take you to a world of very helpful information.
That's great to hear that you use that still, Michelle. Our general website, epilepsy.org.au, also has a load of information, fact sheets, checklists, videos, and a link to the Australian Pregnancy Register. People can register via our website as well.
Yep.
Michelle, it seems to me nothing replaces the expert assistance of treating specialists and the patient actually talking through all of their issues. There are also some great peer support groups, but don't let that replace speaking to your specialist, obviously. But I thought I'd just mention Australian Women with Epilepsy, AWE we were talking about before, is a great Facebook group if you just want to meet other women. But thank you so much for all of the information you've given us today. I think you've answered all of the questions that our viewers were asking, done that very well. So Michelle, lovely to have you here today. Thank you so much.
Well, thanks, Carol. It's been my pleasure. Thank you.